Hello, everyone. Thanks for joining today's session, A Guide to Self-Funding, How to Evaluate a Spectrum of Choices to Manage Risk, Cost, and Care Outcomes. This webinar is sponsored by Nova Healthcare Administrators. Over the last 30 years, Nova Healthcare Administrators has evolved into an innovative health plan solutions company that uses flexibility and creativity to improve holistic, self-funded health plan performance and build a better experience. Every situation is unique. Healthcare solutions should be too. Nova focuses on creating a solution that is both personal and personalized to better serve and support clients and their members. Nova administers self-funded medical, dental, and vision plans, COBRA and reimbursement services, and private labeled solutions for approximately 500 clients with nearly 250,000 plan participants. I'm Sean Edwards from World Congress and Validation Institute. I'll be introducing today's webinar. Just a couple of talking points before we get started. I want to address how we're handling questions. Due to the number of attendees, participant lines are muted. However, if you have a question for our speakers, please do so using the Q&A feature that you see at the bottom of your screen. We'll address all questions we have time to answer today. Also, please note the webinar will be recorded. You'll receive a link to the video so that you can view it again. Now I'd like to introduce our speakers for today. Teresa Vincent is the product manager for Nova Healthcare Administrators. Charlene Zielinski is the director of client services at Nova. And Todd Martin is the chief sales officer at Nova. And now, without further ado, I'd like to turn things over to Teresa to get us started.
Hey, Sean, we're here today to talk about the spectrum of health plan performance management opportunities. And this graphic up on the screen may look very familiar to you if you are a fan of either Sir Isaac Newton or Pink Floyd. And this is really a framework of how we're going to talk through all the different components that go into a health plan. Your health care plan has to be functional. And we know a lot of the time it can really be more frustrating. And we don't want you to waste your time or your money. So we've created this spectrum of health plan performance management opportunities to walk you through all the different pieces. So if you want to look at it this way, the company is the white light source coming into the prism. So from the perspective of the employer group, all you see is one thing, your health plan, your needs for your members. For brokers, it's the same thing. All you see are the needs for your employer groups. But when it comes into that prism of your TPA partner of an organization like Nova, what you see is that instead of being just one thing, it's many things. So within that visible light, this rainbow of options, you will see there are a lot of creative solutions that you need to have a well-rounded health plan that actually changes health outcomes for the good. So within that range of wavelengths of light and then gradients within the different colors, there are a lot of different options. And that's where some of the confusion and I think even some of the frustration comes in. So within self-funding, as you're building your plan, you're really choosing from a menu of things for network, for telehealth, for your wellness program, for medical management, for pharmacy management, for your benefit design tiers of how your benefits are actually going to look and feel for your membership. And then finally, what is your reimbursement strategy if you're going with a high deductible health plan? So we're going to walk through the range of options in all of these different colors, starting with network. And before I turn it over to Todd, you'll see on the screen here when we go through the different colors that we're going from a lighter gradient to a more vibrant gradient. And that really just shows you the range of choices. So we're going to talk about how to look at this range of choices and make your decisions for all these different components of your health plan. So we'll start with network. It's one of the most fundamental components of your health plan. And we're going to look at the difference between structured, hybrid, and open choice. And with that, I'm going to turn it over to Todd.
Yeah, thank you very much, Teresa, and thanks for joining everybody today. So, when we talk about network, the network approach really seems to be doing a 360. And going back to the days when I first got into the business, 10, 15 years ago, national network solutions such as First Health, PHCS, and many regional networks across the country were adequate solutions for the TPA model. Once some of the BUCAs, and I guess for those of you that aren't familiar with the term BUCA, it's something that I'll probably reference throughout this presentation today. But BUCA is really a term that represents Blue Cross, United, Cigna, and Aetna. But once some of the BUCAs started to lease their network, probably, I think, 5-10 years ago, employers really wanted their associates to have access to anywhere, anytime, and at their real convenience. And what we have found with this is there are many limitations to having control as a plan sponsor when you are partnering with a BUCA network. And some of those limitations of a BUCA network solution is a lot of them prohibit steerage, into more cost-effective and high-performing providers. Their bread and butter is their provider relationship, so they want them all to be treated equally. They usually have plan design requirements as well. They also control the pre-certification and prior authorization requirements with really minimal flexibility. Oftentimes you'll see, yes, we want to pre-certify the entire list, or no, we don't want to pre-certify anything. So there's really limited customization. And at the end of the day, the fee schedules of the BUCA networks really continue to go up, at the same pace of the fully insured rates that are out there. So what we're seeing, many self-funded employers are seeing that they've lost control in many aspects of managing their health plan. So what we've seen in the market is really a transition away from, this BUCA PPO solution. The pre-certification and prior authorization process is again being transferred in-house to either a TPA or maybe another third-party vendor that will help increase engagement and education to the membership about, what potential options may be for where they seek care. They're educating more on quality and cost differentials. Plan designs are once again also becoming more narrow and truly designed to drive membership into those more cost-effective solutions. Most non-BUCA networks don't have limitations on plan design and steering membership into specific providers. And this is all really done while developing pre-certification or prior authorization strategies that meet the needs to each one of our self-funded employer groups or plan sponsors. Where on the BUCA networks, they're really designed overall managing their fully insured block of businesses where they have more financial interest vested. In some instances, we are seeing employers actually eliminate the PPO network entirely and moving to a Medicare reimbursement model, which is oftentimes referred to as reference-based pricing. And this model allows for membership really to go anywhere they want, and then the plan reimburses the providers at a percentage above the Medicare allowable rate. This model does have the chance for members to be balance billed, or even more frequently with the noise that we see on these plans is it's at the point of service, and providers and facilities may be requiring that a member or patient is paying 100% of billed charges up front and then telling them to go chase down whatever they can from their health insurance. So there's definitely an opportunity and more than likely that you will see, increased noise with this type of models. But really, if you're going to roll one of these out, you need a sound education and communication strategy out to the membership, and make sure that you have the right partners that are truly going to advocate for the membership when they do sometimes receive a balance bill or have a barrier to seeking care. Another growing trend that we see with the Medicare reimbursement model is to include a direct primary care program. And this is where the employer pays a capitated rate to a clinic or a chain of clinics where memberships can go for services at no out-of-pocket. And when you build the plan design like that, you are going to have utilization at those clinics because there's going to be there will be no noise. And obviously, it's a more cost-effective solution to the member. And this really helps the membership that has historically been avoiding care due to high deductibles to be compliant once again and start taking care of themselves. Another strategy that we sometimes layer as well with the reference-based pricing programs or Medicare reimbursement is to offer a physicians-only network and really then focus the Medicare reimbursement to the more costly facility claims.
As Todd said, there's several different network offerings that our employers can use, and we all know there's not a one-size-fits-all. So with each of our employer groups, we really want to understand any of the challenges that their members are facing. So as Todd also mentioned, it's really about education when you move towards like a DPC model, reference-based pricing. Having that education is extremely important. And understanding that if there is any barriers, what type of solutions can be put into place so that the members and the plan are not being impacted. This table represents one of our clients that has a direct primary care model that uses reference-based pricing for services outside of the clinic. In a DPC model, NOVA is working in collaboration with both the providers and patients to assist in improving employee satisfaction with the plan, engaging members in their health, and following their plan of care for improved outcomes. This model has been proven to be effective for the plans, resulting in lower emissions for their members, as well as resulting in a cost savings to the plan.
And the next piece on the spectrum, the orange color, is telehealth, which is another, like network, very important way to get access to healthcare services. And of course, as we've gone to this more remote environment dealing with the coronavirus, we have seen a huge explosion of telehealth. So we're seeing more demand for the services. We've seen an increase in utilization of the services where people had it already. And it's everything from e-visits with your existing providers, third-party vendors that provide after-hours solutions, and even seeing supplemental to the entire spectrum of healthcare, a lot of solutions for chronic condition management or mental health. And Todd's going to walk us through all these pieces of the spectrum.
Yeah, and telehealth has really evolved, especially since the global pandemic started. It was weird. I actually saw a commercial during the NFL playoff games this weekend of a local hospital system advertising telehealth services. 12 months ago, this would be unheard of. I feel that the growth of telehealth will really allow patients to get care in a more efficient manner, but it's also going to provide more time for the providers to spend time with their patients, that are in true need of attention. So I think it's going to allow providers to really work more effectively, more efficiently, and have a greater impact on, their patients. Historically, over the past probably 5-10 years, many health plans began offering telemedicine programs to their members, really as a cost-effective solution to after-hour cares for simple things like, strep throat, bronchitis, pink eye, and the strategy was to give membership access to talk to a doctor, get a prescription, and without incurring the cost of, the emergency room or the urgent care. And with barriers to care now more than ever, telemedicine should really be embedded into the overall health plan and highly encouraged to utilize through communication as well as plan design. This provides cost-saving measures to the plan, but also gives members access to care 24 hours a day, at a reasonable rate. There are many solutions out there, for telemedicine. So, just some of the things that I have seen through my experience of things that you should really look for when selecting, a vendor. So doing your research is definitely important. And, the first really is understanding, the services that telemedicine vendor offers, and it's not services such as, being able to do virtual as well as telephonic. I think it's more important now than ever, to have a solution that maybe can support, behavioral health. Not all telemedicine solutions can support this, but I think right now, many people across the country are having a hard time, both financially and emotionally, as a result of the pandemic. It's often easier to address these issues, from the comfort of your home, without having to go and walk in to meet, or schedule an appointment, with a psychologist or somebody, that can help you with your emotional well-being. Also when evaluating the solution, make sure there's sufficient licensed providers in the state where your membership resides. One of my earliest experiences with telemedicine, the strategy around implementing it was a very rural population in a very rural state. And, the members on the plan really didn't even have access to any type of care within 30 minutes to an hour. So the strategy around this was to put in a telemedicine program where these associates, wouldn't necessarily have to drive an hour. They might not have to leave work to get a simple prescription. But what we found was, since it was such a rural state, that they really didn't have enough licensed providers in that state to support the population. So in reality, when you think of telemedicine, you're thinking of something where you're going to be able to engage with a provider within a couple of hours. Well, in this instance, it was sometimes longer than a day. So what we were trying to accomplish didn't really work because we didn't do our homework. So just make sure you do your homework, evaluate the services that are available through the program, make sure that there's sufficient staffing and licensed professionals to support it when you're evaluating your telemedicine partner.
I think promotion is also really key when you're looking at a telehealth solution and implementing it to your employee, to the members of the plan. A lot of times that it's available to them, but they're not using it because they don't understand how easy it is to use. And they also don't understand that there's also a cost savings, both to the member usually, instead of having to go to an emergency room or an urgent care center, as well as there's a savings to the plan. I love to always tell our groups that as a parent, I don't want to pack up my children and take them to even the doctor. If it's something that I can just give a quick call to the telehealth provider and get some quick feedback, they call in a prescription and I don't even have to leave my own house and potentially get anyone in the family sick. So this has been found with one of our employer groups that we had expecting and new mothers that were going to the emergency room for things that really could have been handled at a lower level of care. And based on the data that we were finding, we said that we need to find a solution for this group. We implemented telehealth, and we also educated their members, informing them pre-registering, which is also a big barrier that people don't want to have to register. If you're already registered in the system, you can quickly set up an appointment and get the call back. We also register them with our 24-hour nurse line, and we implemented this program to help mothers find in-network pediatricians as well as urgent care centers, so that way they didn't have to necessarily go to the emergency room as their first choice. And as a result, we did see that there was an appropriate shift in the ER utilization.
And as we're seeing telehealth evolve into more of the chronic care solutions, or where you can really look at things like behavioral health or even ongoing management through telehealth, it actually starts to support our wellness initiatives. So we have the traditional organizational wellness, we have wellness programs where you earn incentives, get rewards, and then we're also seeing a switch towards more comprehensive well-being, which could be layered in with telehealth and with other solutions. And now Todd's going to walk us through all the different components of the wellness spectrum.
Yeah, thanks, Teresa. So the wellness buzz, I guess I'd say, seems to have quieted down over the last couple of years. From where it was at 10 years ago, but I still feel it can have a real positive impact on not just the overall well-being of the member and of the plan, but also on as a positive impact on the culture of the organization. Many programs that are out there are traditional opt-in strategies where you get some discounts on some items or maybe even a gym reimbursement. And these programs are great, but the limitations are traditionally you're going to get the people that are already healthy to participate, and you're not going to engage with those that you really try to get walking down a healthier path. While I feel it's important to give healthy members the tools to remain healthy, I think it's even more important to get the membership that may not be taking the appropriate care of themselves to really take action. Throwing a gym membership out there isn't enough for the unhealthy to take action. With the correct design and incentive program, we will have a better chance of engaging those who historically were unengaged. I have always been a fan of incentivizing by reducing employee premium contribution for those that engage. Many employers can put a one-time carrot or incentive out there, but we see more engagement when it's reflected repeatedly in one's paycheck, let's be honest. Once we have the membership engaged, we need to make sure that they have access to the right tools to understand their risks, how they can make healthier choices moving forward, and just become an overall healthier person. The really in-depth, or I guess high-level comprehensive wellness programs that I'm a huge fan of is truly incorporating biometric screenings. A lot of times we have employers balk at the cost of a biometric screening, but in most instances, those screenings, they'll be paid as a claim to the plan. They'll be applied to a stop-loss attachment point. Every stop-loss carrier will allow for that because you're only going to help in the overall health of the plan, and they see value in that. All self-funded plans cover blood work, so why not obtain that blood work in a way that can be aggregated and give some insight to the overall risks of the plan. I know myself personally, when I get my blood work in the mail on an annual basis through my provider, it doesn't really make a lot of sense to me. I typically have to go to my wife, who's an RN. She can give me a little bit more detail on what that little piece of paper means, but it really does not tell a story for me. And most biometric vendors, and definitely the good ones that are out there, they'll provide a detailed report to the member, which explains the results in a manner that is simple, yet compelling. It identifies what the member is at risk for today. It identifies what the member is at risk for 5 years, 10 years, 15 years down the road. And then also makes recommendation on how to reduce these future risks and get any potential conditions under control. And oftentimes when people see that in layman's terms, it's enough for them to act. And what we have found as well, going back to the incentives, oftentimes the incentives for these programs, are participation based in the beginning. So get your biometric screening, you get your incentive. These programs can also evolve over time where they're more results driven. So if you have a health score, in year 2, maybe there's some sort of incentive tied to, getting that health score down and lowering your risk for years 2 and 3. So that's a little bit on how we feel, you can effectively build out wellness.
So there's different levels to a wellness plan. It can be from employee challenges, reward-based programs, and as Todd's mentioned, the biometric screenings. I'm a huge fan of biometric screenings. Not only does it really help to educate the member on their own health and well-being, but through claims integration, we are proactively able to outreach to people that we've identified that might be benefit from a disease management program. And having that, this is the only opportunity, unless a member reaches out to us directly, that we can identify those members and proactively help them on their health instead of waiting for additional claims to come into the system to identify those members.
Having that data that feeds into our medical management program, into disease management programs, is really valuable because we have a team of dedicated case managers that can also provide coaching services. It's not just a one-time thing where you call someone up and say, hey, did you know that you're pre-diabetic? We can actually give people the tools through either wellness programs, through medical management, that will actually help them be healthier, maybe avoid that diabetes diagnosis, and take care of the things that they need to do to achieve what is the healthiest state for them. And that's really what medical management is all about. So we're going to go through some traditional medical management models. What are some creative solutions, and then what are some expanded solutions for care when it comes to managing disease states?
Yeah, I began to touch on this a bit when we were talking about networks previously, but when a self-funded employer is in the standard BUCA model, the population isn't being treated differently than the BUCA fully insured population, and why does that matter? Well, every population is different and strategies should really be customized a bit. I often get approached by vendors that focus heavily on the management of a specific chronic condition. For example, I get approached all the time by diabetes vendors that say all of Nova's clients really need to have this solution. Well, if we don't have any diabetics in a population, what sense would it make to implement a program targeting this condition? So this is where biometric screenings could be so impactful. If we can get participation in a biometric program out of the gate with a new group, then we have immediate data that we can integrate into our clinical platform. This allows us to begin developing a health profile of the individual, but also understanding the driving conditions of the population as a whole. Once the prevalent disease states are identified, we can apply additional strategies around those conditions. This can still be done without biometric screenings. We can do it through integrating medical claims, pharmacy claims, prior authorizations, and pre-certifications. But we obviously have to wait for these actions to be incurred, as well as it doesn't necessarily capture those who are not going to the doctor. And sometimes those are our most at-risk members to the plan. So, leveraging technology and data really allows for the program to be successful. Many programs and engagement strategies are really only being triggered with pre-certifications and prior authorization requests. There's so many other areas where we can identify members from a medical management perspective, one of the largest really being through pharmacy claims. So understanding when maintenance meds are or are not filled, this can be key to keeping someone out of an inpatient setting. one of the things I've always said is that a provider can write as many scripts as they want, but it's only the plan that really knows if these scripts are being filled and consumed at the frequency directed. You know, we often find that if members aren't being compliant to a medication, it truly just comes down to the members out of pocket. You know, they might not have the money. You know, this is when we might work with the employer to develop strategies and solutions around something alternative. For example, you know, if we are seeing inpatient stays, you know, as a result of non-compliant diabetics, then maybe it's something we take to the employer at renewal and say, hey, we're seeing, you know, inpatient stays as a result of non-compliant diabetics. Here's a generic maintenance drug that could keep these people compliant. We would recommend that you cover this at 100%. And you might see a little bit of a spike in the pharmacy spend that year, but long-term goal, we're going to see a decrease in the inpatient stays, which is truly the more costly claim. Many self-funded employers across the country are also exploring things like medical tourism. This can be done both internationally and domestically. It's probably scaled back a little bit, you know, since the pandemic, but prior to that, many employers were actually implementing strategies where they would send people even out of the country, you know, for certain types of care. There are many centers of excellence locations that focus on specific procedures that really can be done in a more cost-effective manner because it's the one thing that they focus on and they're doing it repeatedly. So they really have a fine-tuned process in place. In many situations, it can financially benefit the plan to provide transportation, lodging, and the cost of the procedure for the member in lieu of maybe just running through a PPO network. What most employers do to encourage this and drive utilization and engagement is they will oftentimes share in the cost savings with the member if they use one of these tourism solutions.
So a lot of the times that when we get this medical information, our health plan performance team is identifying claims that then are sent over to our medical management team, and they're performing outreaches to identify those members that may be beneficial or benefit from these programs. If members don't engage, we actually also follow the member from a physician standpoint, and we just keep up to date on any of the diagnostic stuff that's going on behind the scenes. It also then is taken from our medical management team to the account management team, and we are performing outreaches based on barriers that we're able to identify. So as Todd mentioned, it's not necessarily upon renewal. We can actually have those conversations throughout the course of the year because all this is continuously going on, and we really want to help our members take care of their health because at the end of the day, they're going to become better. They're going to be more informed and their health is going to improve as well as the plan is going to see the cost savings. This chart represents a percentage that our plan participants that engaged with the clinical team compared to those that did not for inpatient admissions, and our team followed them as a transitional care. So this identifies what the readmission rates were at day 7, day 14, and day 30. And overall, it kept going down as long as they kept on engaging with us.
So having really good integrated medical management is really important. You have a team that's really dedicated and focused on all these things. We take a group by group approach so we can really dive in on all the specifics using data and analytics tools that we have. We have some pretty deep capabilities so we can really go in and see what it looks like from the individual group's perspective, not just kind of a one-size-fits-all solution. But you know, it really doesn't matter how good your medical management plan is if you don't also do prescription management. Todd spoke a little bit about this, but you really do need that RX management component in there. And you know, in the self-funded world, this is generally provided by PBMs. And there are a few different points on the spectrum. You can have a discount-based PBM, you can have an integrated PBM that folds in specialty RX and maybe some other things. And then you have the consumer-directed model, which we're seeing emerge, that really puts more of the focus on individuals and their spending habits and their options for care. So I'm going to swing it over to Todd to go through all of the options on the RX management spectrum.
Yeah. So while many of our clients overall, their medical trend has remained flat over the last handful of years, you know, we really see the increase coming from the pharmacy side of the house, you know, and there are so many PBMs out there. So how do you really know what is the best one? You know, there's a lot of factors to really consider. Many PBMs pride themselves on buzzwords around transparency and rebates, but you know, what does that really mean around what the plan is paying for the drug? You know, I've seen a number of competing proposals that show a significant increase in rebates to the plan, which looks really good on paper. However, we really should be focused more on the overall cost of the drug to the plan. You know, there's really two types of formularies that we often see. There's the value-based formulary, as well as a rebate-based driven formulary. And, you know, in the value-driven formulary, it will drive utilization to the lowest cost drugs by putting them on tier 1. In a rebate-driven formulary, it will drive utilization to the highest rebating drugs by putting them on tier 1. So what does this mean? You know, in the rebate-driven formulary, you could have a tier 1 brand drug that costs $400 with a $200 rebate. In the value-based formulary, you could have a tier 1 generic that accomplishes the same thing as that brand drug we just mentioned for $20 and no rebate. So in that example, your overall cost on the value-based formulary is $20, and the rebate-driven formulary after the $200 rebate is $200. So rebates really don't tell the whole story. What would your client rather pay? $200 with a $200 rebate or $20 off the gate? So I think that that's something that you really have to peel back the onion when you're evaluating a lot of these savings analysis that are provided by PBMs. Often when there isn't a visible per script administrative fee and rebates aren't being passed through 100% to the plan, it can be assumed that probably they're on a rebate-driven formulary. Rebate management really is crucial to controlling costs. A strong PBM will monitor their formulary on an ongoing basis, and when generics become available, they'll adjust the formulary to drive utilization to those more cost-effective drugs. A strong PBM will also engage with the member and prescribing physicians to try and transition the member to that more cost-effective solution. You know, at the end of the day, there are drugs that cost a lot, and you know, might not be a generic or a more cost-effective alternative. So, you know, how can we pay the most appropriate price for those drugs? There's a handful of different ways that we can do that. As many of you know, oftentimes the uninsured can actually get, you know, these expensive specialty drugs more cost effectively than the insured world can, because many manufacturers offer copay assistance programs to the members utilizing these expensive drugs. So it's important to work with a PBM that has a process that allows the plan and the member to both benefit from these manufacturer copay assistance programs. They offset the cost to the member, they offset the cost to the plan, and it's realized savings to the bottom line. Not all drugs necessarily will have any of the previously mentioned savings potentials. So we can also create savings by encouraging mail order through the plan design. Oftentimes you'll see somebody can get a 90-day supply for 2.5 copays. So that's important. Also, we see more and more plans offering cost savings solutions through international RX programs. It's crazy to think that we can get drugs that are manufactured in our country in other countries cheaper. Most commonly, we don't see that plans mandate this for legal purposes, but they will offer it outside of the plan and incentivize the member to utilize the international RX program through waiving any member responsibility. I would say on average, we have savings of probably between 20 and 30% on internationally sourcing drugs. Some PBMs have these solutions embedded into your programs, but there are also many other organizations that can offer this type of program outside of the PBM itself. You know, one of the other things that Teresa mentioned too was consumerism. You know, we see a lot of technology and apps out there that really give members more choice, where they can look up and have an understanding of what they're going to pay based upon what pharmacy they go to. Those tools are great. You know, there's a lot of PBMs out there that are offering them. Some PBMs are even offering a sharing in the savings if they pick up their drug, you know, from the most cost effective location. Like I said, these tools are great, but you have to understand your population that you're working with as well, right? So if you have an average age of 55 population, you know, and a lot of them are taking maintenance medications, the chances that you're going to get a 55-year-old person that is picking up their same script from the same local pharmacy for the last 25 years to start engaging in mobile technology to try and go to a more cost-effective solution, you know, I think the chances of really getting that type of population to engage is probably low. But if you had a population of, say, average age 32, where that demographic lives on their mobile phones, you know, putting in a program where they have purchasing options at their fingertips could ultimately save, you know, dollars for the plan.
So as Todd said, having the right vendor is extremely important. It's going to help to drive down your prescription cost. Also, when you have the right vendor, you want to make sure there's integration of the RX data into the medical system to help identify any of those gaps in care. Based on one of our clients, that we had data that supported that the members were not picking up medication for maintenance asthma as well as their diabetic supplies. We determined that based off of our utilization management team, that there was gaps in coverage because people were having challenges picking up the medications based on the cost. We then went back to the employer and we did make recommendations to eliminate the copay for those for the supplies as well as the asthma medications. And as a result, it did increase the member compliance as well as reduce ER and inpatient admissions, and overall resulted in a lower cost to the plan.
So once you have a good handle on your medical management needs, your prescription management needs, you've looked at your network, your wellness program, all these things we've talked about so far, what that really feeds into is what your benefit design looks like. You know, we're really creating throughout this color spectrum, the whole ecosystem that goes into the healthcare plan. But benefit design is one of the things that touches members the most. They want to know how much they're going to pay and what's covered and what's not covered. And, you know, a lot of times we inform that when we're working with our employer or broker partners to figure out what the best benefit design is. So that could be level funded, it could be a more standard design, it could be something highly customized based on their needs. So Todd's going to walk through these three components of the product spectrum.
Yeah, so myself personally, I've always been truly a fan of the crawl, walk, run approach. You know, taking an employer from a fully insured or ASO BUCA program to a highly customized program can be overwhelming to many groups and give them a bad taste to the unbundled TPA model. More employers are really looking for alternative strategies to the cards that they've been being dealt for the last 20 years. For many employers under 200, I would say a good first step to a self-funded solution would be a level funded program. You know, a level funded program where they have a strong national network. This would provide for minimal disruption to the membership. You know, it allows the employer to purchase an easy off-the-shelf plan design with a known monthly fixed cost. Traditionally, when larger employers that may already be self-funded, tradition to Nova, really what we do is duplicate the plan design in year one. And again, to minimize the noise and disruption in the population, we'll duplicate the plan design with another strong national network because a lot of times change is rarely perceived in a positive light within member populations. So the smoothest that transition can go, I think it's the best for not only the employer, but for Nova and everyone involved. But in both of those situations, once we start gathering data on the plan, that is when we open up the discussions of what is driving the cost of the plan and how can we more effectively manage those costs. You know, this is often when we begin making tweaks to the plan design, maybe steering utilization, you know, in different directions, putting in more regional approach with maybe a network. You know, this is also when we can start to discuss how we can pay claims differently, such as using strategies like reference-based pricing. Maybe we try doing a direct contract. again, every region and every population is different. So when we make these recommendations, it's truly in a collaborative approach, and education and understanding is always first, the key thing.
So Nova's approach is to really understanding what the goals are of each of our clients, whether they're financial, member focused, or a combination between the two. Being self-funded allows an employer to customize their plan instead of having to select from a standard offering. Having a customized approach, we can identify different services that we want to have prior authorization, having a plan design created around what's subject to the deductible, what's not, creating different co-pays or co-insurance. And ultimately, if we implement something that does not work, we work hand in hand with our employers, as Todd said, and we identify the barriers that people are having. A solution of reference-based pricing as a standard offering sometimes doesn't work, and we do have to back out and we have to take a different approach. We work with our groups to make sure that they have the best situation in place, both for themselves as well as their members. In addition to having a customized plan, we're also constantly looking at different vendors, and Teresa does a wonderful job at that. We're looking at new vendors based off of the data that we're seeing, and we go out and we seek those different vendors, and we make those implementations. And really, it seems to be an impact for our groups. It depends on what's going on again with that population. So a lot of the cost drivers will proactively go out and look for an opportunity and then implement it with each of our groups. And then the last part, it's the last part of our spectrum, which is reimbursement accounts that we at Nova manage. So it's a great opportunity to implement those to help drive down costs for the plan and also help members along the way.
When you have your benefit design, that is one of the things that a lot of employer groups look at is, oh, I want to do a high deductible health plan. It's lower cost. That seems like it'd be really great. But then you have employees that don't like it because they feel like they have to pay so much more out of pocket. But when you pair it with a really good reimbursement strategy, that can actually be something that, people, maybe nobody enjoys using their health plan, but that people feel like they're getting real benefit from. It's not just their employer raised their deductible and that's it. So, looking at the spectrum of either an FSA, an HRA, or an HSA, that can be a really powerful tool that an employer group can use to show that a high deductible health plan can benefit consumers.
Thanks, Teresa. I feel one of the most underutilized benefits in our industry is really the FSA account. I would say almost all of us are spending tax dollars out of our paychecks that could have come from a pre-tax flexible spending account. The utilization of this benefit really needs to be communicated efficiently at the time of open enrollment, and education is always, key and foremost. Because I think we'd all like to be taxed less. I once worked with an amazing HR woman who was able to get 98% participation in the FSA offering around a 500 employee company. She was passionate about it and was constantly reiterating that if you're not enrolled, you're losing money. Health reimbursement accounts, they're another benefit offered by an employer to help members supplement the ever-growing high deductible plans. I have felt that offering a very high deductible plan offset with an employer-sponsored HRA can really be the first step to an employer understanding self-funding if they're in a fully insured arrangement. We don't see a lot of employers offering HRAs once they've transitioned to a self-funded model. They traditionally just lower the deductible to what the previous member responsibility would have been. They still use them from time to time for any sort of engagement type incentive programs. And then last really are HSAs, which have probably become the most popular reimbursement account over the last 5 years, and this allows the member to accumulate dollars for an indefinite period of time. That can be a combination of both employer and employee dollars. And I feel that this allows for members to become better consumers of healthcare. In the HRA arrangement, typically it's employer dollars, and there might not necessarily be concerned on how they spend their employer dollars. But when it is either just your own money or maybe a hybrid of your employer and yourself's dollars going into that account, you tend to make educated decisions. You might shop around a little bit more. So the HSA, it's a long-term strategy for the individual as well. You know, you obviously have investment options as you tend to grow, you know, those balances. But I feel that it's probably one of the most effective programs that we've seen out there today.
Definitely agree. So this chart is showing the differences between an HSA, an HRA, and an FSA. It really is key that when you're implementing any of these, that there's education given to the members. As Todd referenced, that group, it was amazing. They educated their members. They told them they were losing money by just not putting money in that they knew they were going to have to spend throughout the course of the year. There's worksheets that can help identify the cost to the members, so that way they know how to effectively put the appropriate amount of money in without losing it if there is no rollover or grace period, to make sure that the money is actually spent within the given plan year. HSA, obviously, you can use it as you go on. There's no cutoff time. So it's really about education that is the most impactful when implementing any of these, to make sure that members understand them and then they're appropriately able to use those funds. This chart just represents the comparison of each of them, and Nova works with all of them. And our employers really, it's not a one size fits all. It really is based on whatever the members can use. And even if you have an HSA, you can do a limited purpose FSA. So help with the dollars for the vision and dental services. There's a lot of great options out there to help plans save money.
So now we've walked through the entire spectrum of health plan performance management opportunities. And you know what we do within that prism as the TPA, we want to understand the tolerance for change from the group. We want to engage in conversations, going back and forth, walking through all the different gradients and wavelengths like we've done today. And, you know, our ultimate goal is really to improve plan performance and health outcomes. That's what we're here for. That's what we do every day. And what you've seen from the three of us as we've walked through each of the different colors is we represent a spectrum within the organization as well. I keep an eye out on what products and services and vendors are out there. Todd really works with new groups as they come on board and make sure that they understand what they're purchasing. And then Charlene works with the groups over the long term, making sure that everyone stays engaged and that the plan continues to meet their needs and that we continue to hit those performance and outcome goals. So now you've seen the whole spectrum of solutions and we've walked you through everything. We have a poll question for you. And out of all the areas we highlighted today, which one interested you the most? Again, that's network, telehealth, wellness, medical management, pharmacy management, the benefit design tiers, and reimbursement. And we're just going to give you all a second to vote and we'll have real-time results for you momentarily. Okay, it looks like pharmacy management was the biggest vote getter, with medical management the next one. And then we're actually going to have a follow-up question. So keep in mind what your answer was, regardless of whether or not it was the top vote getter or not. And thank you everyone for participating in that question. And then our follow-up poll question, which should pop up in just a moment, is based on your answer, where do you think you fall on that particular spectrum that was of greatest interest to you? Do you think you follow the more traditional route? Are you really interested in more of what's emerging? Or are you really looking and going all the way out to the more innovative, cutting edge sort of, you know, breaking news solutions? And again, we'll show the results in just a moment. So we're going to give everyone just a second to vote. Okay, so it looks like we got a lot of innovators and folks that are emerging on the spectrum. So that's very exciting, and thank you for participating in our poll question today. We are actually breaking down all of the different colors of the spectrum into individual webinars. So if you are available February 10th at 2 p.m., you can join us for a spectrum series entirely about network solutions. There's going to be a registration link in the chat box, and if you follow us on LinkedIn, you'll be able to learn about all of the upcoming webinars. There are going to be 7 in the series total, and we're excited to kick that off next month. And with that, we're going to switch over to the Q&A.
Great, thanks everyone. The first question is a two-part question. What changes do you anticipate coming to new federal price transparency rules? And the second part of that is EEOC has just issued some new guidelines and significant changes about what is and is not allowed with wellness programs. So could you talk about some of the changes to price transparency, and also could you discuss to the best of your ability, some of the new EEOC guidelines?
So I can field this one, and I'm just going to give a more general answer, but feel free to reach out if you have any specifics about any particular designs you have any question about. My background before I was a product manager was I was in compliance, and before that I worked in regulatory guidance. So I make sure that when we are working with vendors, which we do a lot with wellness and other solutions, that's one of the top questions we ask is if they're up to date with EEOC, ADA, all of those things. And we always keep our finger on the pulse of what regulations are coming down the pike. The price transparency question is interesting because it's a really contentious rule. If you haven't read a lot about it, there's a lot of questions and concerns about how that's going to be rolled out. But in the TPA space, I think that where that is going to evolve is we're going to see a lot more price transparency tools that come out on the market over the next couple of years. So we're going to keep a really close eye on those tools as they evolve and see if there are any that are maybe a good fit for our member. Particularly if we're looking at high deductible health plans with HSAs or FSAs, people want to know what price they're going to pay before they go out for these elective services. They want to know how to compare, and we're seeing that with pharmacy. So I think we'll start seeing it with medical as well as the data becomes more available.
Got it. Okay. So when you're cross-referencing data between like biometric screenings and Springbok, how are you proactively reaching out to members? Phone, email, text, mail, and what does a message look like? And the second part of that is, what kind of ROI are you seeing with most wellness programs? How's that being accomplished?
So in terms of, go ahead, Shirley.
For our outreach approach, our dedicated medical management team is engaging in several different ways. We try calling the member directly. If we don't have the appropriate number, we reach out to the employer group to get a better number. That's always the best approach if we can get someone on the phone. If we're unable to get them on the phone, we do follow-up letters. We also do follow-up phone calls at different times of the day, because if we're not able to reach someone during the day, we'll try in the evening and also a different day during the week. And then we substitute it as well as trying to engage them with a letter. We are looking to do a text message approach, but there's very sensitive information given, so we don't want to give them any reason why we're reaching them out to that way. So we have to be careful on our different approaches, but we definitely try phone calls the number one because engaging them that way has been the most successful. ROI.
I'm sorry, I didn't mean to cut you off. Keep going, Charlene.
With the ROI, I just did an evaluation, and we saved on our client, I believe it was over the past year. It was a little bit larger of a group, but it was roughly around, I think it was $96,000. That group had, I think, around 400, almost 500 employees, and the ROI we showed as being around $96,000.
Got it. Todd, question for you. When you're outsourcing drugs through international channels, since it's outside the plan, so to speak, there aren't any rebates. Is that 25 to 30% net savings that you mentioned? Is that accounting for loss and drug rebates?
Yeah, no, I would definitely agree. So I mean, a couple of things to address that. So not all drugs, always have rebates. So I would say that that's, part of the average there. But yeah, at least 20%, even if there is a rebate available most of the time. And for me, it's ironic. So I mean, I'm in Buffalo, New York, and it's my entire life I've actually seen family members, friends, actually go over to Canada. We're obviously 20 minutes from the border. But it's obviously newer model, I guess, across the country. But we've been seeing people purchase drugs in Canada around here for years. So it's definitely mind-boggling to me on how we have to pay more for drugs that are manufactured in our country. Hopefully, there'll be some improvements going on that, in the future. But yeah, I would say 20% is a minimum number, even when you're capturing the rebates.
Got it. And when Nova's allowed to bring the whole prism to bear on a population, are they competitive price-wise to Buka? And if so, by how much? 5, 10% more? And are there sustainable savings?
Yeah, so when you say cost, I mean, I would say when you look at our overall administrative fees, so our cost to manage the plan, they're typically, on par with the Bukas. sometimes a little bit higher, sometimes a little bit lower, depending on the programs, because many times we might be bringing in another third party. We might have to pay a network access fee. Depending on what that network is, could really dictate if we're more or less. Sometimes if we're doing a reference-based pricing model or solution, we obviously have to pay those third parties as well. So we don't mark anything up. Everything we do is transparent. We don't get overrides from PBMs. We don't get overrides from stop loss carriers. So, our fee is illustrated on our proposal and our administrative services agreement. But I truly feel that where the significant savings are is on how we can more effectively manage the cost of the claims. So what we're paying for, making sure that the claims are appropriate. There's not upcoding, there's no unbundling. So we're editing all the claims that come in on a nightly basis for those types of, over excessive fees, as well as we're obviously developing unique strategies, on how we pay for things, whether that's through direct contract, whether that's through reference-based pricing. But I just feel in the TPA model, even if you're going from national network solution to national network solution, we can probably save 5% right off the bat just on more effectively paying the claims, and then hopefully another 5 to 10% on more effectively managing the population and keeping them compliant, and doing things like Charlene mentioned, where we're decreasing inpatient stays because we're helping people eliminate gaps in care.
Great. Okay. Another question. What do you do if a client doesn't want to act on the data presented? How do you handle that?
That happens. It's okay. So with our groups, really, it's a lot of times because we get to know our groups extremely well. We understand what their needs are, again, their member needs. I think that is one of the most important things that we have to do as an account management team, is to understand each of our clients. Most of the time that when we're getting that information, I'm able to weed it out. Or my entire team is, we are kind of given the information, we present it because we have those open conversations with them. But more often than not, I already know when a client's going to reject it or they're going to potentially accept it. It never hurts our feelings. It's the client's plan at the end of the day, and we are here to support them and help them to make the right decisions.
Yeah, and to piggyback on what Charlene said, I mean, what's the old term? Like, you can take the horse to the water, but you can't make the horse drink. And I think it really goes to our responsibility is to share the information and bring recommendations in collaboration with the consultant. Not every employer is right for the same solution, right? So, I mean, that's where we all add value, whether you're a TPA, whether you're a PBM, whether you're a broker. But it's understanding what your client is looking to accomplish and how they want to go about doing it, right? So we talked about the crawl, walk, run approach. Well, if someone's fully insured with a BUCA today, I can save them 15%, 20%, maybe 30% if we flip to a reference-based pricing solution tomorrow. But what's the cause and effect of that? Like, how's that going to downplay with the membership? And to reiterate what Charlene said before, is the employer strictly concerned about finances? If it's an employer that just cares about finances and they don't necessarily have a whole lot of love for the happiness of their associates, that might be a solution that they go down. We have a lot of, school districts, union clients. I don't think that we'd ever put a reference-based pricing program in for one of these, types of employer groups. We could talk to them about it because that's our job. We need to educate. But at the end of the day, if one union member gets a balanced bill, it's not going to be a pretty situation. So, not every solution is basically what I'm saying, it's not a one size fits all approach, or else we'd have universal health care and I would be unemployed.
Got it. And then just a couple more questions to get through because we're right up against it, but I'd like you to squeeze them in quickly if we can. What can you do to improve drug outcomes in addition to lowering costs?
Can you repeat the question? I'm sorry.
Sure, no worries. What can you do to improve drug outcomes in addition to lowering costs?
What can you do to improve drug outcomes in addition to lower costs? I really think that it's formulary management. Like I said, constantly looking at the formulary and understanding what drugs are coming off of patent. A lot of times a generic drug is manufactured by the same organization as a brand drug, right? So understanding when those drugs come off patent, which would be the brand drug, the generic comes out, and working to adjust not only the formulary, but the membership that is currently being prescribed to that brand drug, like having a strong PBM that will engage with that member and work through step therapy programs to get them onto that more cost-effective medication. And it's not only more cost-effective for the plan, but it's also more cost-effective to the member. At the end of the day, we don't want to sacrifice the care. So if a member just isn't responding the same from that generic medication, then maybe it's not the best situation to transition them away. But if we can do so in a non-adverse way, that's the way that we can keep people healthier, because we now get them on a more cost-effective drug, but we're also controlling costs to the plan, where, at the end of the day, that's kind of our role to improve outcomes while controlling costs.
Got it.
And then PBMs too have medication adherence programs, because no drug is effective if you don't take it. So
Right.
That's something really important to consider as well, is what kind of follow-up are they doing to make sure people are actually taking the drugs that are prescribed to them.
Right.
True.
And a way to do that is to allow access for more cost-effective drugs. People will obviously take the drug if it's financially suitable for them.
Great. All right, 30 seconds, then we'll wrap up. One more just to squeeze in. Where does DPC fit in on the spectrum?
I would say DPC is almost a collaboration of all of it, right? So I could see it as fitting in with the network solution, right? So you are steering membership into this place where an employer is paying capitation, and now people can go for services at no out of pocket, so we eliminate those barriers. But now you're creating relationships within the walls of that organization. You're getting more comfortable. So that falls into wellness, that falls into medical management. Many of our DPC providers, with that capitated rate, the membership will also get access to a generic formulary where they can utilize maintenance meds at no out of pocket. So I think the right DPC solution can really touch on everything that we talked about today and have an impact.
Great. All right, well, we are out of time, but remember, folks, there's a link there in the chat. Nova's doing another webinar on February 10th at 2 p.m. The link is there to go register, so please check that out. Thanks, everyone, for joining us. Thanks to Nova and the team for sponsoring today's session and making it possible. The webinar has been recorded. You'll receive an email with a link to the video so you can view it again. To access any additional webinars or get info on how your organization can speak or sponsor, please visit wcwebed.com. Thanks again for joining us, everyone. Have a great day. And this now concludes today's discussion.